All right, so we're going to switch gears now and talk about the child with the gastrointestinal disorder, okay? Now, children with GI disorders, I know time is of the essence when it comes to respiratory, obviously, right? When we're prioritizing. But these kids also need to quickly be assessed because we want to be assessing them for signs and symptoms of fluid loss that can result from GI disorders. So signs and symptoms is that poor skin turgor, depressed fontanelles, dry mucous membranes, or even no tearing when crying. These guys really quickly need to be assessed for any signs and symptoms of that fluid loss. And we're going to talk a little bit about the pathophys as to why next. But I feel these two do go hand in hand because really this is something that's timely, needs to be treated timely to prevent more complications. So I know I always talk about ABCs. Do they have an do they have an airway issue, a breathing issue? Yes, they did with the respiratory. And do they have a circulation issue? Right now, we're dealing with the GI disorder, but what it can lead to is a circulation issue. So it can fall under the category of the circulation, which is why it is imperative that we do a quick assessment and treatment with the kids with GI disorders. So we said fluid loss, right? Signs and symptoms of fluid loss, whether it's through diarrhea or through vomit. We're going to talk about that. We're going to get into the nitty-gritty of that. But the fluid and electrolyte and acid-base imbalance, this is why digestive disorders can lead to that. And I know you guys all absolutely adored Mrs. Brown's F&E lecture last spring at this time, which all of our lovely nursing 2 students are going through at the moment. And they kind of slam that with you, or they slam that on you come nursing 2. That's where you really need to apply your concepts of the F&E lecture to this lecture. And this is why we get so concerned with digestive disorders with kids. This is why we want to take diarrhea, disorders seriously, or just a bout of diarrhea, digestive disorders seriously. So the distribution of fluid in our body compartments, right? It's distributed in these 3 compartments here: intracellular, interstitial, and intravascular. In adults, body water accounts for about 60% of our total weight with adults, whereas in infants, the body water accounts for 75 to 80% of total weight. And then with children, 65 to 70% of their total weight, okay? So it's significantly higher in infants and children than it is for adults, which is why fluid loss can impact infants and kids so much worse than adults, okay? So throwing it back to the acid-base imbalance with Ms. Danow's lecture, some of the fluid imbalances which can lead to the acid-base imbalances, looking at our isotonic dehydration, hypertonic dehydration, hypotonic dehydration, or you don't need to focus on the fluid imbalances, the different types of dehydration, or the different types of fluids. You don't need to focus on that. What's isotonic, what's hypertonic? You had all that in nursing too. But what I want you to know is the acid-base imbalance that is a result of whether it was an isotonic or hypertonic, okay? And can it cause or will it cause a metabolic acidosis or a metabolic alkalosis, okay? So the metabolic acidosis, we see this with diarrhea because the sodium is lost in the stool, okay? So we worry about metabolic acidosis with kids that have diarrhea because of that sodium loss within the stool. So our blood gas analysis is going to show the low pH and a low bicarb, right? You're also going to see an increased acid in the urine, and to compensate for the high CO2, right? Because if they've got low bicarb, high CO2, they're going to have rapid breathing. So they're going to have rapid breathing tachypnea in an attempt to blow off that high CO2. So metabolic acidosis with the diarrhea, and opposite, metabolic alkalosis with our with our vomiting, because of the lost hydrochloric acid within the stomach contents that the baby's vomiting. So with this, you see the opposite. You see slow shallow breathing. Blood gas analysis has a high bicarb, right? Low CO2. So in an attempt to hold on to that, slow, shallow breathing. And one of the most main electrolyte disturbances that we want to take a look at secondary is potassium, hypokalemia. Okay, so anytime they're vomiting, just like with the NG tubes, remember we taught you guys when we've taken all of the stomach contents out, we need to keep an eye on the potassium. The same with the vomiting child is we need to correct the secondary electrolyte imbalance of the hypokalemia. So making sure we're monitoring and administering the supplementive potassium. All right, so let's talk a little bit about vomiting. I know that's a really great title for a slide, right? Vomiting. But what I like here, I have the table here in Pelletieri to differentiate between regurgitation and vomiting, because this is a very difficult thing for pediatricians and nurses to help identify whether an infant is having regurgitation or reflux or vomiting. Okay, so I put this table in here because I think it really does break it down nicely. I know I seem to put all the tables in here, but this is really where you want to know the differences between the regurgitation and vomiting, as well as like the pyloric stenosis, which we'll talk about. But many children, let's focus a little bit about vomiting. Many children with vomiting are suffering from what we call a mild gastroenteritis. All right, gastroenteritis is kind of that term for stomach infection, right? Which can be either caused by viral or a bacterial organism. So when we have a gastroenteritis, we look for those two symptoms, the vomiting, the diarrhea. That's with your children. Now, adolescents, fast forward it a little bit, the adolescents who is possibly pregnant may mistaken the normal nausea and vomiting of pregnancy for an illness. So remember, the nausea and vomiting with an adolescent, it may not be a bad idea to rule out pregnancy, get a pregnancy test, okay? Because we don't want to be treating the adolescent client for gastroenteritis when they are in fact with pregnancy. And some children may develop persistent or cyclic vomiting, okay? So what we want to do for treating therapeutic management for vomiting, withhold food. Many parents treat vomiting in actually the opposite way, whereas we want to keep feeding. NPO, put them NPO, right? Withhold the food. Every time a child vomits, they attempt to feed the child again, which is just kind of adding, salt into a wound. Then the child vomits again, and then they feed him again, and then the whole pattern repeats itself. So this just helps prolonging the vomiting and intensifies the potential for the electrolyte imbalance, okay? So withhold the food. Make sure that they are speaking with the pediatrician. Make sure the pediatrician and the nurse knows, the age of the child, how much they weigh, so that you can tell them properly how much and when, how long to withhold the food for, and if they possibly need to be brought to the hospital for some supplementation, IV fluids, okay? All right, acute diarrhea. Acute diarrhea is associated with infection. All right, chronic diarrhea is likely associated or related to a malabsorption or an inflammatory cause. Some infections, Giardia lamblia, Campylobacter jejuni, Salmonella, C. diff, E. coli. These are very common pathogens that cause acute diarrhea associated from an infectious organism. Diarrhea in infants is always a serious problem, always taken seriously, okay? Infants have such a small extracellular fluid reserve that sudden losses of water quickly exhaust the supply when it comes to their circulation. So anytime we see diarrhea in infants, we're going to take the matter seriously. So therapeutic management for mild diarrhea, oral rehydration solutions, right? Like a Pedialyte or a Gatorade after 1 hour. For breastfeeding infants, we want to continue to breastfeed, right? If needed, measures to reduce fever. So if they have a elevated temperature, we're going to give them measure supportive treatment. And then our severe diarrhea, what we want to do for babies that have, children that have severe diarrhea, temporarily rest the GI tract. So we're going to want to temporarily rest that gut and then oral or IV rehydration therapy. All right. We want to discover what the responsible organism is for the severe diarrhea. So really trying to get a stool sample on that. We want to try to get. And then antibiotic therapy if indicated, depending on the result of the organism. All right. So this is from a continuation from when I was talking a little bit about the regurgitation versus vomiting. I want to talk to you about reflux versus pyloric stenosis, which can they present very similarly, and it can be a challenge on differentiating whether the patient has just simply reflux or if they've got something wrong with their pyloric sphincter here. So let's talk about gastroesophageal reflux, okay? On assessment, what we see within infants is a history of effortless vomiting, okay? And we can look at the pH of the gastric secretions as well, which can tell us that it's coming from their gastric region, right? So we're going to look at the pH of the gastric secretions themselves. We can also do an endoscopy or an esophagography or an esophageal manometry, all these different types of diagnostic tools to help rule out gastroesophageal reflux. Okay, in adolescents, they may report heartburn, a complaint of heartburn. Right, in our babies, infants, they can't complain of any heartburn, so we have to do a little bit more diagnostic studies on them. Whereas with the adolescents and the older they get, they can report a history of heartburn. And then if severe, we can do an endoscopy on them, okay? How we want to treat this, how we treat once we've ruled out that it is reflux, right? When they have that effortless vomiting, we want to thicken the formula. So thicken the feeds to help keep it down. So infants, feed formula that's thickened with rice cereal, while holding the infant in an upright position. And we want to keep them in an upright position, either in an infant chair or in like a car seat, at least for an hour after the feeding. So positioning here really plays a key. So we're educating these parents, thicken the formula. When I say thicken it, add rice cereal to the formula and make sure that they're upright while eating and at least for an hour afterwards to help kind of gravity is going to be of assistance with this. And it also helps prevent any aspiration as well. Okay. We also can prescribe them some H2 receptor antagonists that may be prescribed daily once they've ruled in gastroesophageal reflux, GERD. In adolescents, give them some education, right? Over the counter or prescription H2 receptor antagonists, like your omeprazoles or Zantac. Pyloric stenosis, this occurs in infants when the pylorus blocks food from entering the small intestine. All right, so what we see with these kids is vomiting immediately after feedings. And with this, it's generally projectile, okay? That projectile vomiting, I think of the P in pyloric stenosis with projectile versus just the spillage or the leakage, almost like with reflux. Reflux doesn't generally tend to be projectile, whereas the pyloric stenosis does. And this is because that pylorus sphincter is enlarged and it's blocking the food from entering that small intestine and kind of rebounds it up. So the kids vomit immediately after feeds. They have like a sour smelling vomitus without bile. There's not going to be any bile in it. You're going to see dehydration with these kids. You're going to see alkalosis with these kids. You're going to also be able to palpate and visualize a round, firm sphincter, which is kind of classic of the pyloric stenosis. So how we want to treat this is we want a pyrotomy, right? Where they go in and kind of relieve that blockage, that obstruction. They open up that pyloric area there. Want to keep them NPO until surgery, and then IV fluids, make sure that we put them on IV fluids, and then we do the surgical or laparoscopic correction of pylorotomy. Peptic ulcer disease. Some things that we see with peptic ulcer disease in infants is we see hematemesis or melena. So we may see blood-tinged vomit or blood-tinged stools, okay? Really from that irritation of the digestive tract, the upper digestive as well as the lower digestive. So in infants, you're going to see the hematemesis or melena. In our toddlers, you're going to see anorexia, vomiting, bleeding. So they may just not want to eat, just hurts too much to eat. In the earlier school age children, that's when they're going to start to be able to report pain and discomfort, okay? Your school age and adolescents, they report epigastric pain. They report that epigastric pain that's relieved by eating and then causes vomiting or epigastric tenderness. So they suddenly have a relief after eating, but then it causes a vomiting and then that epigastric tenderness. So we'd want to get an endoscopy on them to kind of rule this out. How we treat this, triple therapy. So in children, it's called triple therapy. 2 antibiotics, usually amoxicillin and clarithromycin, which is Biaxin, as well as a proton pump inhibitor like your omeprazole, Prilosec, and Pepto-Bismol, right, which is a soothing and mildly antibiotic. So this may be prescribed concurrently. All right, 2 antibiotics, the proton pump inhibitor and the Pepto-Bismol, bismuth subsalicylate. All right, hepatic disorders. I'm just going to touch a little bit on hepatic disorders. I'm not going to focus too much of this on the test. However, you do need to know the hepatic disorders when it comes to the pediatrics, and it does fall under the line of digestive disorders. So obstruction of the bile ducts. What we're going to see with on assessment is really kind of what you guys are going to expect. Jaundice can develop around 2 to 6 weeks of age when they have some kind of an obstruction of the bile duct at congenital. Lab findings will show an increase in their direct bilirubin as well as their alkaline phosphatase levels. Those are going to increase the the ALT. They may have a normal AST in the early phase that later becomes abnormal. So we don't want to be looking at the AST, which is the SGOT. That may be in the early phase is normal, but then it progresses to abnormal. So we don't really look at that AST immediately. But we're also going to be looking at poor absorption of fat and fat-soluble vitamins. So CAD, the vitamins K, A, D, and E, right? As well as poor absorption of fats, as well as calcium absorption. So they're going to have poor calcium absorption, a low calcium in their diet. Excuse me. And what we're also going to see with these kids are the light colored stools. So, everything that I talked about when I did my biliary lecture back in the fall is very similar to with the pediatric kids, right? So how we treat it, obstruction of the bile ducts with treatment. For an atresia, we're going to surgically correct. So a surgical correction, removing the obstruction, as well as liver transplantation for children that have extensive involvement or in whom the procedure is not successful, right? The surgical procedure is not successful. Hepatitis. With Hep A, how we want to treat Hep A, increase rest, so making sure that they're resting, and good caloric intake, right? So A, after eating, right? Increasing rest, good caloric intake. Hep B, we're going to put them on the antiviral meds, such as interferon, entecavir, and lamivudine. So we're going to put them on the antivirals for Hep B. Chronic hepatitis supportive compensation for the decreased liver function. So once they start to really decline in their liver with chronic hepatitis, then it's just going to be supportive treatment. And fulminant hepatic failure, when they have complete hepatic failure, we're going to give them the lactulose, the non-absorbable antibiotics, and these guys are going to be the liver transplant list. All right, so intestinal disorders, specifically with the kids, all right, because I know that you guys learned about this with our adult patients with Dr. Robinson, but intestinal disorders pertaining to the pediatric clients, a lot of this stuff, I will say, you will see on your NCLEX. There usually is a couple, when it comes to digestive questions, these little intestinal disorders is what they ask. Stop it. So necrotizing enterocolitis, NEC, we call it NEC. This is where in the first week of life, you see a distended, tense abdomen, where they test positive for occult blood, and it can also cause apnea, so it affects their breathing. Okay, these kids have signs of blood loss. They have an increasing abdominal girth. And on CAT scan or ultrasound, you're going to see air in the intestinal wall or abdomen. Okay, so that's what we're going to be seeing on assessment. And this is the necrotizing enterocolitis, which is where a portion of their intestine becomes necrotic. Okay, whether it's due to an obstruction or a congenital cause. So we see that distension, very difficult to palpate, very firm on palpation. They're going to have positive occult bloods. This is going to cause respiratory problems, which is going to cause their apnea, an increase in their abdominal birth, as well as air trapping in the intestinal wall or abdomen, as seen on scanning. So how we want to treat them? IV, right? Definitely IV fluids and TPN solutions. So we're going to be putting them on TPN, IVs, antibiotics, and then we're going to be going in and surgically removing that necrotizing portion of the bowel. Short bowel, short gut syndrome. This is where they have insufficient bowel surface area, right? What we want to do with these kids is adequate hydration and proper intake of the essential vitamins that they're missing out on, that they're inadequate of. Vitamins and mineral replacement. If surgery is required, then they're going to need long-term use of TPN and or liver transplantation may be necessary for these kids. So vitamins and minerals and adequate hydration and TPN. Appendicitis, I think we all know what appendicitis is. What we're going to see with kids here when the appendix becomes inflamed, anorexia, pain or tenderness in that right lower quadrant, nausea, vomiting, elevated temp. It may not be extremely high as seen with like infectious, but they can have an elevated temp from that immune response. We're going to see a leukocytosis, so their white count's going to be high, and we're going to see an inflamed appendix on the ultrasound or CAT scan, right? And we go in and surgically remove it. Celiac disease, which is that malabsorption syndrome or gluten-induced enteropathy. What we see with our celiac kids on assessment is poor growth. On the history, we look at poor growth. We look at bulky stools with them, malnutrition. They can have that distended abdomen with that poor cachexic-looking appearance. So, like, think of like that third world country kids, the bony or cachexic appearance with the swollen bellies, the distended abdomen. They're also going to have anemia. And on serum analysis of the IgA, the anti-gliadin antibodies, we're going to do a serum analysis of the IgA, which is going to show a positive celiac disease. Okay, and we can biopsy the intestinal mucosa too to help rule out the celiac disease. So how we want to treat this? Gluten-free diet for life, right? Put them on a gluten-free diet, water-soluble forms of vitamin A and D supplementation. So A and D are specifically important when it comes to celiac. If the anemia presents, we want to be supplementing them with iron and folate supplementation. Aganglionic megacolon, also known as Hirschsprung's disease. So what we're going to see with the Hirschsprungs, they're going to be thin, these little babies, these little infants, thin and undernourished appearance. Okay, we want to make sure that we get a bowel history. And what you're going to see with bowel history and on exam is there's not going to be the presence of any stool in the anus area because of the obstruction there. So what we need to do is go in and surgically repair, remove the affected section of the colon. So this has to do with the nerve endings of the colon itself. Aganglionic, which is the nerves. They lose the nerve endings within that portion of the bowel. So it's causing them to be malnourished, thin, and they're not passing any stool. They just become more and more distended. So we got to go in and surgically remove that portion. Okay, intussusception. This is something that you do want to know about. Intussusception can, I don't want you to confuse it with Hirschsprungs, the aganglionic megacolon. But the intussusception is when the bowel kind of telescopes in and of itself here. Okay? So what this does is it causes extreme pain in the infants. Pain, not eating. They kind of like flex their knees, not passing any gas. We want to get an ultrasound to help rule out any kind of intussusception where we'll see that telescoping of the bowel. It can be considered a surgical emergency, okay? Or we can try for it to reverse itself, kind of untelescope itself, by instilling a water-soluble solution, like a fleet enema or a barium enema, or even air. Okay, we can put some air into the bowel to see if that reverses the invaginated portion of the bowel. And if it doesn't fix itself or resolve itself with these treatments or measures, then we need to get them for surgery. Okay, surgical correction. One of the classical manifestations that is often seen with the intussusception is like a red currant jelly-like stools. So bloody stools that resembles almost like a red jelly, or we call it red currant jelly stools, red currant stools. Whereas the volvulus with a malrotation, this is like an abnormality of the bowel that usually develops in utero. Okay, and what happens is it twists on itself so that the blood supply gets cut off. So no blood supply, no flow, no oxygenation through that portion of the bowel that kind of twists in and of itself. Okay, this is actually a very life-threatening problem. So this is one where we're not going to we're not going to give them an air into the bowel or a barium enema to see if it reverses itself. This cannot correct itself, cannot reverse itself because of the twisting portion of it. So what we need to do, this is considered a surgical emergency, and go in and surgically correct it. So I know that you guys have learned about Crohn's and ulcerative colitis. You have learned that in nursing too. You don't have to really, I don't really focus too much on it. You do need to know it when it comes to the pediatrics, but I put this little table up here for you guys to look at. I also like this table because it's disorders caused by food, vitamins, and mineral deficiencies. It's so important why we look at starting vitamin and mineral supplementation within our kids, especially if you look at the demographic areas and all the things that can cause. All the deficiencies, all these vitamin, mineral, and food deficiencies, and what they can cause in the child and how it can kind of arrest their growth and development. So I like this because it shows what vitamins can cause the deficiencies, the signs and symptoms, what we're going to see with these kids. Don't focus too heavily on this, but it is good. You do briefly need to be aware of this. Okay, so now that we talked about the pathophys of our GI disorders. Let's apply the nursing process just like we did with respiratory. So assessment, diagnosis, outcome, planning, implementation, and the outcome evaluating. So we talked a lot about assessment, right? What we're going to assess for significant and correlating manifestations. So nausea, vomiting, diarrhea, right? Stool and vomitus description. We want to auscultate, visualize the abdomen for contour, palpate it for firmness and distension, get an abdominal girth circumference. We want to look at the degree of dehydration with these kids. So look at the color of the skin and the mucous membranes. Look at the fontanelles. This is really where it's important to tell us fluid volume deficiency versus fluid volume overload in our infants and our neonates. And think about your diagnostic tests, right? Ultrasounds, CAT scans, stool samples, EGD. So some appropriate nursing diagnoses pertaining to our kids with the GI illnesses can be impaired parenting. I like that one because it's really like involves the family, right? Impaired parenting, especially for kids if they go for surgery. We may not be talking chronic hospitalizations. You know, these can be acute problems. So these acute problems can be emergency situations. It can be a cause for concern, a cause of alarm. So this may result in like an impaired parenting. Interrupted family processes as well kind of goes hand in hand with that. Obviously, the risk for deficient fluid volume, we're going to want to correct that. Imbalanced nutrition. So this is where imbalanced nutrition goes to play. And a situational low self-esteem, especially for your adolescent-y kids. We want to pay attention to that. All right, guys, question 1. A 3-year-old male is diagnosed with intussusception. Which symptom reported by the parents would have led the nurse to suspect this diagnosis? A, projectile vomiting. B, right lower quadrant pain. C, bloody mucousy stool. Or D, rebound tenderness. The answer is going to be C, bloody mucousy stool. Projectile vomiting, remember that's with the pyloric stenosis, right? Right lower quadrant pain, that's seen with your appendicitis, right? But C, the bloody mucousy stool, also known as the red currant jelly stool, is a classic sign of intussusception, right? The presence of blood with the mucus in the stool, in the bowel movements as the digested food is blocked from advancing past the point where the bowel is telescoped. So that's why we see that bloody mucousy stool. All right, a school-age boy has an emergency appendectomy. Which assessment should the nurse report to his physician if noticed in the immediate post-op period? A, abdominal pain. B, a feeling of tugging at the incision site. C, thirst. Or D, a rigid abdomen. And once again, this is no different from nursing 2 when you guys learned the appendix. So the answer is D, a rigid abdomen, right? Peritonitis. One of the first symptoms of peritonitis, which is the infection of the peritoneal cavity that we get concerned about when there is appendicitis and the rupture, is that tense, rigid, distended abdomen. All right, question 3. The nurse discovers that an infant is developing necrotizing enterocolitis, also known as NEC. What is the best action? So what's the first thing that we do when we think of we discover that the baby is developing necroenterocolitis? A, institute NPO status. B, insert a glycerin suppository. C, count respirations. Or D, dilute the next formula feeding to 13 calories per ounce. The answer is, what's the best action? What's the first thing that we're going to do? A, institute the NPO status, right? The damaged ball, the necrotizing ball, is unable to process food. So keeping it free of food and to rest it is important.